Now, let's come to the treatment of asthma and COPD. And I can divide the treatment into two categories. What are you going to do for asthma patients and COPD patients when they do not have exacerbation? What we call the chronic treatment of asthma and COPD. And the other section will be what are you going to do during exacerbation. Let's start first with the drugs that we use for asthma and COPD. You can divide these drugs into two big categories. Drugs that dilate the bronchi, direct bronchodilators, and drugs that just reduce the inflammation, anti-inflammatory. For the bronchodilators, mainly we have the strongest bronchodilators ever are the beta agonists. And next to them are the anticholinergic medications or the antimuscarinics. All these drugs are administered by inhalation, whether by metered dose inhaler or by nebulizer. A weak bronchodilator that's not so commonly used nowadays is theophylline. It used to be used a lot in the past, but now it has been replaced by the stronger beta agonists and the safer antimuscarinics. The beta agonists and the antimuscarinics, we can have short-acting and long-acting versions of them. The short-acting beta agonist, we write it as SABA, short-acting beta agonist. An example is albuterol, and the long-acting is salmeterol or formoterol. The short-acting antimuscarinic, SAMA, is ipratropium, Atrovent, and the long-acting is tiotropium. And we have a lot of combinations. I can combine albuterol with ipratropium, and this will give me the famous drug Combivent. On the other hand, the anti-inflammatory, the most important and the most frequently used anti-inflammatory is the inhalational corticosteroids, ICS, fluticasone, budesonide. And because it's usually harmful to use LABA alone in asthmatic patients, long-acting beta agonist, it's better always to combine it with inhalational corticosteroids. Remember, never administer long-acting beta agonist as a single medication to an asthmatic patient. Surprisingly, you can give it to a COPD patient, but not to an asthmatic patient. It increases the cardiac-related mortality. So we can combine LABA and ICS. We can combine the long-acting beta agonist with the inhaled corticosteroids, as in Advair Diskus and in Symbicort. In Advair Diskus, we combine salmeterol and fluticasone. In Symbicort, we combine formoterol and budesonide. Other anti-inflammatory are drugs against leukotrienes, montelukast, Xyluten, they are leukotriene antagonists, and omalizumab, which is a monoclonal antibody. But the major drugs used for treating asthma and COPD are the bronchodilators, the beta agonists, and the antimuscarinics, and the anti-inflammatory ICS. For COPD patients only, we can also use roflumilast, which is an anti-inflammatory phosphodiesterase 4 inhibitor, and we commonly and routinely use antibiotics. We can think of the drugs used for asthma and COPD in another way. The short-acting ones, whether the SABA or the SAMA, are the rescue inhalers, the relievers. What to do during the attack. I have attack now. I cannot take my breath. I'm wheezing. What to do? Let me give you something that acts fast, but it acts for a shorter period. SABA, albuterol, or SAMA, ipratropium. On the long run, what are you going to do for me? I can give you a long-acting bronchodilator to keep your bronchi dilated for a long time. Long-acting beta agonists for formoterol, salmeterol, long-acting antimuscarinic, anticholinergic, tiotropium, or Spiriva. What else? I can give you steroids. Steroids will decrease the inflammation and on the long run will help your bronchi kind of dilate. Inhaled corticosteroids, most commonly used, fluticasone, budesonide. Oral steroids, I will only use them during exacerbations. I will not put you on oral steroids for life because of the side effects of steroids. So let's do a comparison between how are you going to treat asthma and how are you going to treat COPD. And it's kind of stepwise approach. For each stage of severity of asthma or COPD, you prescribe a medication. For the next stage, you keep the medication of the first step and you either increase the dose or you add another medication to it. So let's start by the treatment of asthma. If you have intermittent asthma, all what you need to do is albuterol PRN, rescue inhaler, SABA, short-acting beta agonist as needed. Mild persistent asthma, you start using low-dose ICS, and of course you keep the albuterol PRN. Moderate persistent asthma, you are going to use medium-dose ICS for moderate persistent asthma, medium-dose ICS, and if still the patient is symptomatic and not well controlled by the medium-dose ICS, you can add to the medium-dose ICS long-acting beta agonist. Remember, never use long-acting beta agonist in asthma without ICS. In severe persistent asthma, you use high-dose ICS plus LABA plus systemic steroids, oral prednisone. And in severe persistent asthma also, you can consider drugs like omalizumab, you can consider drugs like leukotriene antagonists like montelukast. So this is the management of asthma. For COPD, group A, mild symptoms in low-risk patient, just Combivent PRN. Combivent is what? Combination of albuterol and ipratropium. Group B, severe symptoms, but the patient is low risk. In Group B, I can use long-acting bronchodilators, whether salmeterol, formoterol, LABA, long-acting beta agonist, or long-acting muscarinic antagonist like tiotropium. Group C, this is what? This is the high-risk patients, FEV1 less than 50% of predicted, but mild symptoms. Once the FEV1 drops less than 50% in COPD patients, this is the time of ICS. Notice there is a difference here. In asthma patients, we usually start ICS earlier. In COPD, we tend to start ICS later. Why is that? Because the use of ICS, inhaled corticosteroids, is associated with more tendency to infections. And COPD patients are very vulnerable to infections. So the use of ICS early on in a COPD patient will increase the frequency of pneumonia. So we keep it until the FEV1 has fallen below 50% of predicted. So in Group C, I give long-acting beta agonist or long-acting muscarinic antagonist plus ICS, usually moderate dose ICS, and I can add also roflumilast, which is an anti-inflammatory. And notice that I keep Combivent all through. The last group, Group D, I have severe symptoms in a high-risk patient. This is like the kitchen sink. You put everything together. Long-acting beta agonist, long-acting muscarinic antagonist, ICS, Combivent, roflumilast, and you start regular courses of antibiotics. Usually it is azithromycin. For both categories, asthma and COPD, stop smoking, avoid triggers, be on top of your immunizations, flu and pneumonia. For COPD, you might advise pulmonary rehab. Oxygen, if the patient is hypoxemic, also improves survival. Question: which of the following lowers mortality in COPD? Two things: smoking cessation, continuous home oxygen therapy.